So what is the pathophysiology behind malaria? So as we saw already, it mainly involves the RBCs. There is rupture of the RBCs. Once the organism infects the RBCs, it alters the membrane, it deforms the RBCs. So there is hemolysis. Okay, there is altered membrane deformability, and these deformed RBCs are immediately removed by the spleen, right? And also there is hemolysis, there is intravascular hemolysis which occurs. So this causes anemia, and because of hemolysis, the patient can also have jaundice. Also there is anaerobic glycolysis. Within the RBCs, the organism undergo anaerobic glycolysis. There is increased production of lactate, there is increased production of acidosis. Lactic acidosis can also occur, and because of the anaerobic glycolysis, the patient can also present with symptoms of hypoglycemia. Another cause of anemia is because of the hemolysis that happens, there is increased production of cytokines, and these cytokines again can cause bone marrow suppression, and there is decreased production of RBCs resulting in anemia. Okay, so anemia in malaria, one because of intravascular hemolysis, because of the multiplication of the organism. Second, there are ingested cells, the ingested RBCs, the membrane of these RBCs are deformed, and these cells are immediately removed by the spleen, resulting in splenomegaly also. Okay, and these two are the important mechanisms that results in anemia. Also, these patients, malaria patients, they develop enlargement of liver and spleen. So what is the pathophysiology behind this? Mainly venous congestion, there is slowing of blood flow, there is venous congestion, and especially in falciparum malaria, there is sequestration and microvascular obstruction, which we will discuss in little detail. So this causes the obstruction of the microvascular circulation of liver and spleen, causing enlargement of the liver and spleen, and of course there is hypersplenism. The spleen is overworking in destroying all the deformed RBCs, causing splenomegaly. Okay. The patient can also develop thrombocytopenia, one because of hypersplenism, two because of, especially in falciparum again, there is formation of microthrombi in the smaller microvasculatures, right? And along with the thrombi, the platelet also gets adjacent to these thrombi, resulting in thrombocytopenia. So this is the simple pathophysiology behind malaria and the symptoms that we encounter. So what is the pathophysiology of severe malaria? Again, severe malaria is seen predominantly, more than 90% is seen with falciparum, rarely can occur in vivax. Okay, but it predominantly severe malaria is seen with Plasmodium falciparum species. So the basic pathophysiology behind falciparum severe malaria includes cytoadherence, rosetting and sequestration. Now what do you understand by cytoadherence? As the name shows, infected RBCs are going to adhere to the endothelial cells of the smaller blood vessels. How do they adhere? These infected RBCs, once the organism is within the RBC, what happens is these RBCs, they develop some sticky knobs on the surface. Okay, sticky knobs on the surface of the RBCs, which actually are composed of parasite produced proteins, especially Plasmodium falciparum erythrocyte membrane protein 1, which we call it as Plasmodium falciparum erythrocyte membrane protein 1. So these, they form the sticky knobs on the surface of RBCs, and these go and bind to the endothelial receptors of the capillaries and smaller blood vessels. So this causes adhesion of the infected RBC to the walls of small blood vessels, especially of major organs like brain, lungs, kidneys, right, leading to obstruction, and there is endothelial barrier breakdown, endothelial dysfunction, and there is inflammation, ultimately resulting in tissue damage and organ dysfunction. Okay, that is first pathophysiology, cytoadherence. And what do you understand by rosetting? So the infected RBCs, they adhere not only to the endothelial cells, they also adhere to the uninfected RBCs. So infected RBC, so you have the organism here, they adhere to the uninfected RBCs also to form rosettes or clumps. These again can aggregate and obstruct the smaller blood vessels, causing reduction in the blood flow. And there is another process called agglutination, which means there is infected RBCs, they clump with other infected RBCs to form aggregates, which process is also called as agglutination. So rosetting is infected RBC binding to uninfected RBC, forming clumps. Agglutination is infected RBC binding with other infected RBCs to form clumps. All this again is going to cause microvascular obstruction. And what is sequestration? So a combination of cytoadherence, rosetting, all this is going to result in sequestration and blocking of the infected RBCs in the vital organs. So some smaller blood vessels, capillaries, in all these places, these rosettes are going to adhere to the endothelial cells and ultimately block the blood vessels. So this is called as sequestration. So when this happens in the brain, the patient can present with cerebral malaria. So when it happens in the lungs or kidneys, this is how it presents with multi-organ dysfunction. So this is the basic pathophysiology of severe malaria. So you have cytoadherence, where the sticky knobs which composed of Plasmodium falciparum EMP, erythrocyte membrane protein, adheres to the endothelial cells. And you have rosetting, where the infected RBC binds to uninfected RBCs and form clumps. And all these sequester in the smaller blood vessels.